Good afternoon, and thank you for taking time to join this webinar from wherever you may be working this afternoon. SOL's goal for this discussion was to take survey feedback from May's event and continue to discuss the COVID-19 topic from a local perspective. Today's program is being recorded and you should be muted, and our panelists and moderator will be able to speak. My name is Jack Hallmark, and I have been a active ACHE and SOL member for many years and have the privilege to be on the board and participate to co-chair the events with my colleague, Lydia.
Hi, everyone. My name is Lydia Napa. I work for the University of California, San Diego. I've been with ACHE since 2014 and SOL since 2016. It is a pleasure and honor for myself and Jack to be with all of you today.
Great. Some of you in the audience today are representative of SOL's annual sponsors. We want to introduce you to the current 11 platinum sponsors and 1 gold sponsor. Tell you why they are so important to us, why we appreciate them so much. It is very simple. We can't do what we do without the support of our sponsors. SOL's members are both aspiring and established healthcare leaders. As a chapter, we are very energetic and ambitious with a lot of dedicated people. Until the pandemic, we would put on about 10 programs or events and networking opportunities annually for our members and for the community. An executive program, a mentoring program, a program to help prepare aspiring leaders prepare for the ACH fellowship exam. All of this activity is capped with our annual conference. What you may not be aware of is that approximately 45% of our revenue comes from sponsorship. Sponsor support helps us truly do what we do. On behalf of SOL, thank you for your generosity.
Thank you, Jack. Now the San Diego Organization of Healthcare Leaders has several social media platforms. So please, if you're interested, follow us on social media to get the most updated news and program. And also, you can visit our SOL website. We also want to recognize our Live Well San Diego partner in partnership with the County of San Diego. Next, we'll be going over our agenda.
Our topic today is based on survey feedback from May's event. The delivery of healthcare has changed significantly during the pandemic, and you'll hear and see how SHARP and UCSD are advancing healthcare while also overcoming barriers to provide care through this model. Our moderator today is Tim Smith. He'll introduce you to the panelists, and then we'll share their insights and experience. We'll then follow the presentation with Q&A answers and close out today's events. You'll also see in the chat window a reference to the question and answer process. Tim Smith is the CEO of Sharp Memorial Hospital and has been with more than 30 years of hospital and healthcare management experience. Prior to joining Sharp in 2007, he served as interim chief operating officer at University of California Irvine Medical Center for 2 years and was CEO of Fountain Valley Regional Hospital for 9 years. Mr. Smith is a fellow of the American College of Healthcare Executives, serves on the Life Sharing Executive Advisory Board in San Diego, and is the treasurer of the Trauma Center Association of America Board and Executive Committee. He is a former California Hospital Association board member and former chairman of the board for the Hospital Association of Southern California. Mr. Smith earned his Master's of Public Health and Health Services Management from the University of California, Los Angeles. Mr. Smith and his wife have 2 sons, Brad 30 and Brian 28.
Jack, thank you for that nice introduction. Let me say I have the pleasure of introducing our 3 speakers that you see on the screen now. Each one of them have made an impact with their organizations during this pandemic crisis. And it reminds me of the saying Winston Churchill made back in World War II, never let a good crisis go to waste. And these 3 team members have made a big difference, and we're going to hear from them in just a minute. Let me say our 3 speakers. Our first one will be Lisa Moore, who is the Executive Director for the University of California Telehealth Collaborative and Telehealth Program Director for UC San Diego Health. As the executive director, Lisa is responsible for developing a UC-wide telehealth program, leveraging individual UC campus expertise and best practices to allow for cross-campus sharing of telehealth services. Lisa is also responsible for overseeing UC San Diego Health's telehealth and e-consults programs. Lisa has over 15 years experience implementing IT and electronic health record systems, as well as expertise in change management and process improvement, including being a Sigma Black Belt. She also has experience at Rady's Children's with some of these initiatives. Our second speaker will be Dr. Scott Upton. He's an internist practicing with Sharp Healthcare and spent the last 15 years serving as a hospitalist and a primary care provider with Sharp Community Medical Group. Dr. Upton is also the Sharp Healthcare System Physician Advisor for Utilization Management, Clinical Documentation Improvement, and Clinical Appeals Departments. During the COVID pandemic, Dr. Upton has turned much of his efforts to help serve with the telehealth specialty committees that have helped set up extra work at Sharp Healthcare. Our third speaker will be Brian Lichtenstein. Dr. Lichtenstein is a medicine hospitalist with Sharp Staley Medical Group at Sharp Memorial Hospital. He has provided not only clinical leadership, but also extra clinical work focuses on quality and practice management, particularly as it relates to improving physician efficiency and satisfaction with the electronic medical record. Recently, during the COVID pandemic, he has helped focus and coordinate Sharp's efforts to respond to the pandemic coronavirus. And by the way, if you hear him break out a little ukulele riff, you'll know a little bit about some of his personal time. But without further ado, let me introduce the main event and get started with Lisa Moore. Lisa.
Thanks, Tim. Thanks for the nice intros. And thank you, Sol, for having me today. So as Tim mentioned, I have a dual role with the University of California as the executive director of the collaborative, the Telehealth Collaborative, as well as the program director for UC San Diego Health. So I'm going to give you a little overview today of both, starting with UC San Diego Health. So next. Great. So here is just a snapshot of the UC San Diego Health portfolio of our telehealth programs. So we have a pretty robust program of e-consults. We have 18 specialties that provide a consultative model from primary care providers to specialists regarding specific patient needs. We also have our provider to patient workflow that involves both our outpatient MyChart video visit integration with video VIDYO, as well as using our inpatient workflow with Zoom. And that's mostly used between our campus locations, Hillcrest and La Jolla. We have a provider to provider workflow. This mostly involves us having some type of contractual agreement with community hospitals where we provide our consultative services in either telestroke, teleneurology, or telecritical care. And then a newer portfolio that we've been expanding upon is our consumer to providers. So these I refer to them as consumers, not necessarily as patients, because it could be any consumer out there that's looking for a second opinion on a diagnosis that they've received, and then reach out to one of our specialists at UC San Diego Health for a second opinion. So next. So as we all know, COVID hit. And we started really the shelter in place in March. It was extremely taxing on all of our health systems. So the response from UC San Diego Health was we created a Telesprint Initiative, which was to roll out a large scale implementation of our MyChart video visits for all of our patients. We really wanted to make sure that our patient population was social distancing, as well as helping navigate for our visitors, providers, and employees. So our timeline was that on Thursday, March 12th, we really formed the Telesprint team. Then by Saturday, March 14th, we really started to develop our ramp up schedule and our plan. By that Sunday, we were able to train over 1,000 of our providers and staff on the functionality as well as workflows of our MyChart video visits. And then by that Monday in March, we were able to not only convert 1,000 of our in-person visits to MyChart video visits, but also start completing any on the fly or as needed MyChart video visits for any of our patients that either had COVID symptoms or just needed to be seen for other reasons. So next. So through our Telesprint accomplishments, as I mentioned, sort of our ramp up, in the 3 years prior to COVID, we had only completed at UC San Diego Health about 800 of our MyChart video visits. And then within our first week of really having this large scale rollout, we had over 1,000 visits just in our first week of go live. So it was a very quick, rapid ramp up that we had to be able to implement. So the training all of those providers, we took a lot of time of converting those face-to-face to MyChart video visits. We staffed up a command center so that our providers and staff had a way of contacting us for any type of support needs that they had, either technology-wise or workflow related regarding their video visits. As I'm sure a lot of us were aware, during the March and April timeline, legislation was constantly changing specifically for all of our telehealth requirements and services. So we were having to quickly pivot or interpret new legislation and make changes as appropriate. We distributed iPads and iPhones to all of our staff to make sure that they had the devices to use. At UC San Diego Health, we have adopted solely a mobile device strategy. So we're only using mobile devices for those video visit encounters. We had a ton of technical support that helped with us. And then patient outreach, we proactively reached out to over 5,000 patients to make sure that they had a MyChart account. That's our patient portal within UCSD. And then also walk them through the steps on how to have a MyChart video visit, just to make sure that they were prepared if that were needed. And then we added all kinds of new functionality within those first few weeks. We added a multi-provider if there was a care team that needed to see a patient, so multiple providers being able to all have the video visit at the same time with the patient. And then we had a copay or a guest pay functionality. I'll talk a little bit more about our affiliation with El Centro Regional Medical Center and what we did with them. We also implemented our inpatient Zoom consultations. So again, there was less exposure going on from unit to unit with those COVID patients. And then we also integrated our interpreter services within the video visits. Next. So this is a view of our dashboard, our telehealth dashboard that we created to give real-time data to all of our staff, leadership, so that they can really see dynamically what is going on in our current environment. So this gives a nice glimpse at where our current percentage of telehealth visits are today. So out of our total ambulatory visits, we're seeing about 37% via video. Next. So this actually down below shows a nice bar chart of where we started. It was more of a 50-50 ratio, and maybe even more 60-40 of telehealth encounters to in-person visits during shelter in place. So next. Now we're actually really seeing this shift back to more in person, but that's where the 37% video visits still comes into play, that we are averaging anywhere from about 30 to 40% that we're still having via video, and we want to continue that. We know from a social distancing standpoint and also just a convenience on both the patients and the providers that they want video visits. So we're actually looking at, even post-COVID time, of really trying to maintain this 30 to 40% video visit rate. Next. So a little bit of background on how we also helped El Centro Regional Medical Center. So as I think a lot of you have heard or did hear, the Imperial Valley was a real big hotspot for COVID. So we have an affiliation with El Centro Regional Medical Center, and we help to provide tele-ICU services to the staff at the hospital to really help them ramp up for the surge and the amount of COVID patients that they were seeing. So we noticed that there was the patient visits per day increased by 70%. And within the first 3 months, we were able to help provide guidance with some clinical interventions that El Centro and really, most hospitals had not been aware of. The prone positioning was one major area that was identified more from New York and brought out west, as far as the type of treatment and care that you should provide for a critical care patient that had COVID. Next. So here's just a quick glance at UC San Diego's future for telehealth. We're looking at 4 buckets of attracting consumers. So again, these may be non-patients of UCSD, and they may want a second opinion or other type of maybe urgent care type needs. So we're trying to make it as accessible as possible for all potential patients. Expanding our reach, we have an international telehealth program, and we actually also really utilize that in Mexico to provide guidance and care for them during this pandemic. Reduce cost, using wearables and RPM. Not only is that a more a better use of saving costs and helping with at-risk population, but we're also starting to see CMS reimburse for these types of telehealth visits now. And then increase access. So really using MyChart video visits to quickly fill in any no-shows that we have, maybe routine follow-ups, med and lab reviews as well. Next. So quickly, I'm just going to give you now and shift an overview to the UC Telehealth Collaborative, which we've also named as UC Health Anywhere. Next. So the UC Telehealth Collaborative was really created to provide seamless continuity of care by UC providers for UC patients. So really utilizing maybe a provider that's located in the San Diego area to be able to see a patient that's up at UC Davis and vice versa around the state of California. So this is comprised of UC Healthcare Leadership, our IS department, our clinical leadership, student health services, coding compliance legal, and our School of Medicine. And this has really given us an opportunity to share best practices, coordinate on our policies and exchange of data. Next. So to really wrap up the activities that we've done for the UC Telehealth Collaborative, as I mentioned, we're really leveraging our provider base across the whole state of California. And we're doing this with our core values. So quality, coordination, convenience, and our alignment of our core values. And then we are using specific phases to go through our deployment of UC Telehealth Collaborative. So we're really focusing first on telemental health for students, faculty, and staff. That is going to be our first focus and pilot. From there, we were going to add additional telehealth service lines. And then after that, we should have a really robust infrastructure to be able to expand to other UC students and patients across the state of California. Next. So this is just a map of where we're all located. We have 11 campuses through the state of California and 6 health systems. And I will wait and see if you guys have questions at the end. Now I'm going to let Dr. Scott Upton kick off his presentation.
Great, thanks Lisa. It's really interesting to see other systems in San Diego. I know at Sharp we were pivoting quickly at that same time, and I'm in a clinic right now with 10 providers. I can imagine what it was like educating 1,000 providers in a couple of days for telemed as COVID hit. So thanks for having me. I am a primary care provider at Sharp Community Medical Group, and I'd like to give you a little bit of a ground level view of what telemedicine is like for us. So on the next slide, you'll see what is telemedicine. This is us providing care through a computer, through the web, connecting to our patients that way. And there are a lot of different platforms that are out there. I think most of the EHRs are separate from the telemed platform. So the telemed platform is just a different way for you to connect. I know Epic has integrated that into the EHR, and that's probably the next step. But this is a really hot field, and there's all sorts of companies and startups in this field. So on the next slide, I think it's important to understand, when you look at the massive explosion of telemedicine, one of the things to look at was the conditions that supported this. We talked about the telemedicine platforms that had really been developed over the past decade, but not been extensively used, and they were ready to go. But the other thing that is not as apparent was a massive shift in the documentation requirements that happened in 2019. So there's been a lot of work from the AMA lobbying CMS to change some of the so-called the E&M coding guidelines, which is the Bible for physicians in terms of what we would need to document to bill for a certain level of code. And I know on the presentation it says CMS has updated its E&M coding guidelines, but really they just did a complete remodel. And basically what they said was that the sole determinant of the level of code that we could bill for would be based on the medical decision making, which is basically the problems, whether we, how many prescriptions we sent, what data we reviewed, and it would not be required to document anything in terms of the physical exam or the history elements. So that would just be up to the physician. So this was originally developed and approved in 2019 to really help us spend more time with our patients and less time documenting things that weren't necessarily applicable to the visit. But what it actually did was it actually allowed telemedicine visits to be coded for at the higher level, because with the telemedicine visit, as you'll see, I'm going to bring up some screenshots here, there really is a very limited physical exam. And so these rules were put into place in 2019 to be implemented in about 4 months on January 1st, 2021. So then, and this is for everybody. This is for the office and every visit. So when COVID hit in April 2020, CMS came out and informed us that the outpatient telemed visits would be reimbursed at the same rate. So the next question was, we're doing telemedicine visits and they're all level 3. They're not a full level 4 visit. And it only took them a month to shift and tell us that we didn't need to document the physical exam and we could bill for the higher level of code. If this piece wasn't here, we would all be probably taking close to a 20% pay cut. And this was just complete serendipity that all of these coding requirements had been in place. It just so happened that the telemedicine surge happened right after that. And so it was pretty easy for CMS to shift over and to just approve, make this change. I think this coding requirement is going to be really important in the outpatient setting to allow us to continue to use telemedicine and really for its success long term. And then the other condition obviously was COVID, which forced everybody to use telemedicine. So on the next slide, you'll see with all these conditions there, this is some national data. In the orange are the telemedicine visits. And you can see, as we saw with the UCSD data, just the explosion in orange. And this went up till late May. And as you can see, if you're a couple months behind on your data, you're ancient. So everything's shifting so rapidly. Back in May, nationally, we were at maybe a 50-50 telemedicine in-person visits. And it's since changed a little bit. On the next slide, you can see this is some of Sharp-Rees-Steely data from their ambulatory side. Again, looking at February through July, so a little bigger window. And in the orange, you can see the telemedicine visits coming up, getting really popular in April. And then more recently, as clinics have opened back up, the telemedicine visits have slowed down a little bit. More patients are coming into the office, but you can see that looks like it's about 30% telemed right there. And that's what we're seeing in my clinic as well. You can also see that the total visits are not at full capacity either. So patients are still not coming in. They're doing telemed and we're getting them into the office, but it's not like it used to be, but it's getting better. So next slide. So let's go now from the press box down to the playing field. So this is what our life looks like as a primary care provider, down in the grass. Sometimes it feels like down the weeds a little bit, actually. But this is a typical schedule for most primary care providers, an average of 18 to 20 patients. This is actually just a screenshot of my schedule a couple weeks ago. And we'll start from the right side and kind of work our way over just to make a couple points. On the red arrows there, those are all of the video visits, the telemedicine visits. So these telemedicine visits really are easy to work in. On this particular day, I saw telemedicine in the morning and in-office in the afternoon, but they very well could have been a hybrid model. So they're exchangeable with the in-office visits. The circle there where it says a phone visit on the mid-right, that is the one person out of the entire day who did not want to use a video visit and because she didn't have a phone. She was 90 years old. So most people have phones. This is very easy for people to access. And then if you look over sort of in the middle, you can see under the time column there, most of us in the outpatient setting see patients on this schedule. So this is sort of a stacked schedule. And you can imagine how a lot of our focuses are staying on time, being prompt, and the telemedicine visits are very easy for that because the telemedicine visit, as we're seeing patients on the computer, is a little bit quicker. The physical exam is a little quicker. Obviously, there's not as much of it. We're not taking vitals. We're asking them to give us their vital signs. And patients are also showing up. So it's a lot easier to get them on the video. So they don't have to drive and get in the car and try to get here 15 minutes earlier. There's a lot less no-shows. So it's another benefit. And then the last column on the left, you can see after we complete the encounter, the little money sign comes up there. All of these visits are equivalent. So a telemedicine visit with the red arrow or an in-office visit get paid at the exact same amount. So you can see how popular that is with the physicians. I think most physicians, when they look at their schedule like this, the telemedicine visits do not slow us down at all. And in fact, I think in a lot of ways it can actually speed up the process. So flow-wise, telemedicine works. And on the next slide, we're just going to take a screenshot of what it looks like from our perspective. So on the right is just our telemedicine platform. That's me there, but that would be our patient that we're talking to. And then on the left, we would just pull up our EHR. And you can see we can as we're talking to the patient, put in our history. We can review data. Screen sharing option is nice, so we can screen share radiology results. We can review data, look at labs, look at ER reports. We can send prescriptions over. Everything that we need to do is right here. And another thing that's interesting, as you start to use this technology more, is looking at sort of the flow of the visit. If you look at this visit, next time you're on a telemedicine visit with your doctor, look at their eyes. It's very hard to tell that they're not actually looking at you. They're not actually looking at the screen. So on an in-office visit, it's very obvious when a doctor's not making eye contact and they're not present and their face is stuck in a computer screen. It's a little bit harder to tell with telemedicine visit because this is what our screen looks like. It's only about 2 inches to go back to look at somebody's face and to go back to the EHR. And this has just become sort of the new normal. So next slide. So the cat's out of the bag with telemedicine. This is the way that I feel about it. It gives us a lot more options to practice medicine. Like I mentioned before, a hybrid model with the same reimbursement. This is really the grease that's going to keep this train going, is some of these coding requirements that have changed that just make the telemedicine visit completely equivalent from a reimbursement standpoint. Telemedicine is a really nice fit for a lot of patients. So I have a lot of patients that really like telemedicine, and I can tell you they're not going to come in. So I have a lot of patients some patients from Orange County, some patients from Ramona that usually would drive an hour to come and see me. And sometimes for very minor things that they really didn't need to come and see me, and they're loving telemedicine. So access is actually a little bit better. And of course, all of our millennials, the younger generations, they live on social media, they live on their phones, and this is just a natural fit for them to access their doctor through telemedicine. I think for physicians too, telemedicine is a better fit for a lot of doctors. In our practice, we have 10 physicians, and we are all fans of telemedicine. It works. We can break up our schedule a little bit easier for some of our physicians that are in the last stages of their career. They can easily go part-time. They can work from home. And you could practically run a hybrid or a telemedicine practice from Hawaii, basically on the beach, as long as you've got an operator, set up appointments, and an MA to carry out tasks with you. So on the next slide, just wrapping up, I hope that gives you a little bit of an idea of what this is like from the primary care standpoint. And the way that I think about telemedicine is just a really novel tool, although it's not that novel anymore, to deliver quality care in uncertain conditions. But I can tell you, after the storm of COVID passes and the seas are calm, we're still going to be riding this sailboat, this telemedicine train, because it works too well. And another factor, I just want to mention, we're not talking as much about this, is that we needed telemedicine. So a year ago, I can remember going to talks about the big concern was all of the venture capitalism money that was going to small businesses that were getting into the healthcare market. Companies like One Medical, where, with developing these apps where they could get their medical care outside of insurance. And this is something that telemedicine has allowed us to just grab onto this and totally get into the market. So I really think that it's been a really great thing for the outpatient setting, and it's here to stay. So with that said, I'm going to pass it over to Dr. Brian Lichtenstein, who's going to talk to you a little bit about inpatient telemedicine.
Thanks, Scott. So I'll continue the nautical metaphor here for a half a second. I think certainly those of us on the clinical side, generally speaking, are a little bit more of toe dippers and cliff jumpers when it comes to adapting to new practice patterns. I think COVID, like everyone has said here a few times already, has really pushed us into the deep end. So we didn't really have a lot of opportunity to dip. We just took the jump. So next slide. I'm going to speak a little bit today on the inpatient side of things, of what we did at the Sharp Metro campus and how that rollout has been going on over the last half year or so. So a half a lifetime ago, all the way back in February, we actually had a little bit of telemedicine service already at the Metro campus and other Sharp sites. Really what these were the robots that I'm sure a lot of you have at your facilities that was being used predominantly for telestroke services, as well as for supervision and assistance with complex catheter-based management procedures. So at the Metro campus, our robot was not in high use, and was actually parked in a closet, inoperable because it needed new batteries. And so when COVID hit, we tried to get it serviced by the company, but unfortunately they weren't able to do so because of the restrictions during the pandemic. And so our cath lab manager, Donna Dassinger, actually served as the mechanic, the troubleshooter, and the implementer of our telemedicine program, literally putting new batteries in the machine to get it going. Shortly thereafter, when our COVID command center launched, our operations team and leadership started to look to other opportunities to expand our telemedicine program as part of the pandemic COVID response, and look to see what we could do with our robot, as well as a few iPads that we already had in stock. So we initially created an ad hoc work group, and that was really to decide what the best practices were, what was appropriate use cases, who the best patients might be to receive these services, and realize early on that it was going to be a complex undertaking that would require a lot of coordination between our IT group, our physicians, and our nursing leadership to really make sure there was a smooth rollout. We'll talk about this in just a half a sec, but we actually used our clinical expertise and our Lean Six Sigma black belts to really make sure that as we were expanding this, our standard work was something that would be broadly applicable to lots of different use cases, as well as adaptive to each entity throughout our system. It really did not take that long to get going, at least on the small scale at the Metro campus. Our go live was March 16, 2020, just I think a couple days before the big shutdown that we had across the state. The first 2 weeks went really well. We had a lot of positive feedback from providers, from patients. And so Sharp Healthcare decided to make a commitment to telemedicine, including expedited purchase of a few robots for the other campuses to again expand planned services that were going to happen anyway, as well as additional iPads and carts to facilitate our inpatient care. We go next slide. So over the last 6 months, 5 months or so, what we've seen is really an expansion of services, not just for physicians, but for other allied health providers and other patient services. So I'll go into the weeds here in just a sec, but that includes physician telemedicine. Our music therapists and spiritual care teams were actually very early adopters of telemedicine for our inpatients. Our palliative care advanced practice nurses and our advanced illness management team have been using it quite successfully, as has the psychiatry emergency team. These are the folks that do basically our 5150 and 5250 assessments in the ERs. I don't have a dedicated slide for them, but we know that their turnaround time from the time of triage request to actual evaluation has dropped by about a half hour, from 1 hour to 30 minutes during the pandemic, in large part because they haven't had to staff an individual specifically to each emergency department. They can staff multiple sites from a remote location. We've had family conferences that have been highly successful in telemedicine, and a lot of patient support groups. And these are more in the kind of prehab realm, so preoperative care for joint replacement patients, as well as antenatal support groups. And anecdotally, the RSVPs for that and the actual attendance has been really good. We've seen a lot of patients prefer that as a teaching modality, and they've been very successful. So on the physician side, we really focused initially on our COVID positive patients and those under investigation. And in the last few months have really looked to expand the telemedicine services to non-COVID service lines and subspecialists. So we'll take a look at the numbers here on the next slide. So early on, our targets really were the COVID positive patients and the PUIs. In general, these were the stable patients who were already admitted, and the physicians were providing follow-up visits or discharge services. The hospitalists were far and away the largest users of these telemedicine services. They made up the vast majority of our cases, but we actually had some specialists using it on pretty early, as well as spiritual care and other service lines. And I think as our PPE use as our PPE access improved and our mitigation strategies became less critical, as we had a better comfort level with COVID, as we had a little bit better understanding of how those patients might fare in the hospital, I think our hospitalists and other hospital-based providers have dropped off actually in their use. But what we've seen is a reciprocal increase on the subspecialty side. And so that's allowed us to maintain a fairly steady service line of about 180 or so telemedicine visits in the hospital per month. August is a little truncated there. That's just the first 2 weeks. We'll go to the next slide. This is more of the same. Basically, you're seeing the positive and PY patients for COVID in green, and the negative patients in, positives in yellow, the negatives in green. And again, as you're seeing through the course of the pandemic, as with outpatient, we're seeing a big shift in who's using the telemedicine services and for what patient groups. Go to the next slide. What did the patients say? In general, we've been actually surprised how much the patients have liked this. They say the video quality and the audio quality are surprisingly good. And interestingly, with all the PPE, a lot of our patients, particularly those who are hard of hearing, those who might be older, and those who have a little bit of a communication barrier, actually find that it's easier to see their doctor and communicate via telemedicine because they don't have a mask or a PAPR or a lot of physical distance between them. They can actually have an engaged conversation, and it feels a little less stressful, I think, for some of the patients. Next slide. Our physicians seem to like it quite a bit too. One of our pulmonologists has remarked on a number of occasions, both for outpatient and inpatient, that he's amazed, is the term he keeps using, at the quality of care that he can deliver with telemedicine. One of our endocrinologists actually attributes telemedicine to the sole reason he's been able to continue his practice. He has a pre-existing medical condition that puts him at particularly high risk for SARS-CoV-2 infection. And the use of telemedicine allowed him to continue his practice for both outpatient and inpatient-based endocrinology consultations. And I think far and away, what I hear again and again, probably after the first or second visit that someone's done, is that the physicians say, by and large, why haven't we been doing this all along? We know it's not for every patient at every encounter, but this is pretty cool. Next slide. So to circle back, once we formed our ad hoc committee and we understood that telemedicine was here to stay, we actually transitioned to a more formal charter. So we pulled together a committee to basically coordinate compliant tech platforms, to use telemedicine to enhance the delivery of care across Sharp Healthcare, and develop the best set of practices for both the implementation of telemedicine services as well as the vetting and approval process for rolling in new services as those developed. Next slide. This is a fairly simplified workflow. I don't want to belabor the point, but you can kind of think of this as a fast track, slow track, and no track when we think about implementing new telemedicine services. So at our entity level, we have our telemedicine site coordinator who basically reviews any new requests that come through to see if they're already in keeping with our guidelines. If they are, and they don't require any additional technology, any additional equipment or staff, that can be fast-tracked for almost immediate implementation. If it looks like it's in keeping with our guidelines, but may require more technology, more capital equipment, more staff or personnel, in that case, what we need to do is go through our local committee and then ultimately up to Sharp Telehealth Steering Committee at the organizational level for review and approval. The third group, these are the folks that are coming to us with maybe requests that are a little more out there, or maybe an excellent future direction or innovation, but we don't currently have the ability to undertake. We still track those in case we can circle back later as our capacity improves to see if they're willing to roll that in. So if you go to the next page. One of the things that makes inpatient a little bit more difficult than outpatient telemedicine in terms of volume tracking is that, like Scott mentioned, this is not paired with anything in our EMR natively. And so while we have robots, we have iPads, we can actually query the service providers for the audiovisual software. We can't understand which patients we're seeing or for what reasons. And to that end, what we started very early on was an internal tracker to make sure we were keeping an eye on the activity, the department, which providers were using the platform, what platforms we were actually using, what equipment we were using, and especially as we rolled in new service lines, who those points of contact might be and what the barriers to facilitation could be. Next slide. So as you're hearing again and again, we've committed to taking the plunge and we're looking to expand telemedicine services now. Our focus really is to look in kind of two different veins. One is for consultations, follow-up, and discharges for clinically stable inpatients or outpatients for whom we think the telemedicine visit would actually expedite their care. So you can imagine this might be the patient who needs an urgent but not emergent surgical consultation, and the specialist isn't available for 4 to 12 hours, but might be able to sneak in a 30-minute or quick inpatient telemedicine consultations to help us advance the care plan. We're also looking to our specialists who actually have continuity relationships already existing with those patients. This might be an outpatient rheumatologist or oncologist who could, again, help facilitate the inpatient care plan and provide meaningful augmentation of services to patients rather than a substitution even for what's already out there. So I'll say, as we dive into the deep end, we're still holding on to our life vests, and that we do think that inpatient visits are the gold standard still for our inpatients at Sharp hospitals, but we're pretty excited about how telemedicine has allowed us to expand our uses and really improve the access that patients have to all sorts of providers and care. So with that, I'll hand it back to Tim, who I think will take over now for our Q&A.
Great. Brian, thank you very much. And thank you, Lisa and Scott. Appreciate your fine contributions and information insights into UC San Diego and the UC systems use of telehealth, as well as Sharp Healthcare, both at the clinic level as well as at the hospital level. Jack, may I ask you any comments you want to make about Q&A before we jump into it?
I think if anybody has some additional questions, please put them in your chat box, and we'll be referencing those when it's time prevails.
Great. Thank you, Jack. So please use the chat box. Let me start with a couple of questions while we monitor the chat box. Let me see, we talked a lot about physicians and different types of physicians using telehealth. I want to ask each of our speakers about what they think are the physician specialties that really lend themselves the best to telehealth, and especially on a go-forward basis. Please reference those specialties with regard to both clinic as well as hospital, because there may be a difference on what works best for them. Let's start with Lisa.
Thanks, Tim. You know, I think there's been a huge shift, as we've all talked about, especially with telehealth reimbursement. So that has opened up the floodgates of all different specialties really being able to utilize telehealth now. Before, we had tried to look at models where we're using telehealth for cost efficiencies, or I know UCLA was using telehealth a huge amount for their post-op visits because they could have it as part of their global billing. But you know, from a peers specialty perspective and not based on reimbursement, I mean, it is why the UC Telehealth Collaborative is focusing on mental health services, because that's one of the easiest areas that we can be able to provide a virtual visit without needing to physically touch the patient. Derm is also a great way, especially from a store and forward perspective. Those post-ops, as I had mentioned, or even pre-ops and consults, those are really expanding even more in the telehealth arena.
Great. Thank you, Lisa. How about Dr. Upton? Your thoughts on specialties?
So what I've seen, you know, it's funny, when COVID first came out, as primary care physicians, we were flooded with messages from our specialists about how they could see patients. Just let you know, cardiology, we're seeing patients, GI, derm, they needed the patients, they wanted the referrals. And most of the subspecialties in the outpatient setting, most of them are seeing patients virtually. There's a couple that are a little bit harder. Orthopedics is one. For an orthopedics new consultation, you need to lay hands on. Some of the neurosurgeons have done post-ops for virtually, but I think a lot of those new patients that are really surgical, they're like to see them in the office. Same with ENT, but pretty much everybody else, we're all using it. So it's pretty popular.
That's great. Dr. Lichtenstein, how about in the hospital setting?
You know, I think the cognitive-based specialties are ones that really lend themselves well, particularly if you're thinking about a different type of model that really has not been implemented before, which is a clinic-based provider consulting to an inpatient. So you can imagine endocrinology, rheumatology, medical oncology, those sort of specialties where they're really doing a lot of cognitive labor, but may not need to do much of a physical exam, aside from a general gestalt. We've actually had a lot of interest from our surgeons for post-operative checkups, particularly in the co-management venue. So, for example, a hospitalist like myself might be managing a patient following a cholecystectomy. It might be a relatively routine case, the major issues might be hypertension, blood pressure, things like that afterwards. So it may be very reasonable in certain venues also to have some of our more physical-based specialists, our surgeons in particular, who are liaison and co-managing with our hospitalists and critical care doctors to provide some of those consultations or follow-ups for stable patients also. So it's been a pretty big mix. We've had a lot of success with palliative care, in particular in the hospital setting, which again isn't one of those ones where time and face-to-face interactions matter a lot, but actually laying hands on a patient may not be as important to that job.
Thank you. Well, checking the chat box, we have many questions. Let's just kind of jump right into a few, see how many we can get through in the rest of our time. First question, do you see more resistance from patients or from providers with regard to telehealth? Lisa?
Yeah, that's a great question. Honestly, probably providers. Don't kill me, guys. But just, you know, changing the workflows and the way that they, you know, it really shouldn't change the way they practice medicine, but I think not having that sort of personal in-person interaction is hard for some providers to be able to adjust to. On the patient side, you know, it's so easy for our younger generation to catch on. Even our senior population, though, has really embraced video visits and been able to start doing them fairly easily.
Great. Thank you, Lisa. Dr. Upton, anything you want to add to that?
Yeah, I mean, from my standpoint, when things first started, there was some resistance from patients, but as people have just gotten used to it, I don't think there's a lot of resistance at all, at least from in the outpatient setting from what I see.
Right. Brian, Dr. Lichtenstein?
Yeah, I think that in general, we've seen a little apprehension on both sides. On the provider side, we've really made it opt-in in the hospital. So I think it's finding the right patients for the right type of visit. So it probably does not make sense, for example, to do an evaluation on a particularly complex medical patient or unstable patient for sure. We want those patients evaluated in person. For a fairly stable COVID patient, maybe a 25-year-old that's just parked on a high flow oxygen, hanging out in the hospital, that might be a very appropriate one. And so what we've encouraged our providers to do is start with kind of the easy ones, the ones where there's not a lot of complex medical decision-making. A lot of the conversation is going to be about the diagnosis, about the treatments, and less about the physical exam. So, and then on the flip of it, I would say the patients seem generally fairly receptive, but what we've noticed is that if the patients only see providers again and again via video, we do start to see a little bit of concern on their part that they're not being seen in person by a physician. So we really do encourage kind of a balance, especially if it's going to be a patient who's hospitalized for a while.
Great. Thank you. Great insights and answers. There's a couple questions about wearables. So let me throw them out a little bit and have Lisa start with them. One is regarding wearable devices and just trying to understand what health systems are actually using them in conjunction with outpatient care. And then more specifically, someone asked about which platforms or apps do you trust to enable patients to actually get accurate information and convey them electronically to their providers, and can they actually tie those back to the electronic medical records? Lisa?
So I would love to say that we have a robust RPM program, but we're still, most of our devices are still in research mode. So we're using research patients and an IRB model. It's also because of reimbursement still. The new CMS physician fee schedule just came out for calendar year 21, and it still doesn't look great for reimbursement. So we've been actively trying to respond back to CMS and make sure that we have a fair reimbursement for the work effort involved with these wearables.
Thank you. Dr. Upton or Lichtenstein, anything else to add to the wearables? Nope.
Sounds great. I'd love to see it. We don't our clinic.
You'll second that motion. All in favor? Great. Well, a future state then. Just a few more minutes. Let me try and get another question or two in. There's a question about telehealth international work. A couple of people asked, Lisa, what barriers have you encountered and how did you overcome them? And then also specifically, are there any legalities influencing service between the United States and other countries?
You know, funny enough, we had, before the COVID waivers were in place, it was much harder, and still is. There are still measures that we want to put in place for across state lines for practicing care. So pre-COVID, the providers were only allowed to provide care to patients that resided in the same state that they had a license. Since waivers have been placed, they have removed those barriers during COVID, but I would still say there's liability issues and risk involved with that. And California specifically has not been part of a state pact for providing care across state lines. Internationally is still a little bit of the wild, wild west. Again, there's risk involved. I always consult with our lawyers, and we try to really still do a consultative model. So it's provider to provider. It's fine if the international patient is there with their provider, but we usually like to do a consultative model and not provide care directly to the patient in another country unless we have some type of contractual agreement with that organization.
Gotcha. Thank you, Lisa. Down to our last couple minutes, I want to sneak in one more question because Nick has asked it twice on the chat. Is there a difference in billing based on clinic visits versus telemedicine?
Ooh, sorry, I don't mean to keep, but I just really quick on this topic, which makes me super, super excited. So in that telehealth dashboard that we had put together at UCSD, we also have one for our billing, reimbursement, and collections. And we've actually been able to compare the reimbursement based on RVU and straight dollar amount of claims for in-person versus virtual. Right now, because of all the waivers in place with COVID, we are getting an equal amount of reimbursement for our face-to-face as we are doing for telehealth. Don't know, that was never the case before COVID, and I don't know that that's going to be the same for after. But right now we're getting an equal amount of reimbursement. So it's fantastic to see from a reimbursement standpoint.
Great news. Dr. Upton?
Yeah, I can second that, at least from in the outpatient setting for like the CPT code is the exact same. So you're actually submitting the identical CPT code. So like for an outpatient visit, typical for a PCP, established patient or a new patient, be like a level 3 or a level 4. Rarely you would submit a level 5. And very similar for the specialist, it's the exact same code. There's just a modifier on that with a video code attached to it, but it's identical. So it is the same right now. And you know, the other factor is that when CMS came out with their guidelines, they really did say for outpatient that we're going to be the new rules, and in 4 months it's going to be the same. So they've already done all the legwork. They didn't do that as an inpatient. So from the inpatient side, there's all this temporary language, temporarily approved, temporary during this COVID. So the outpatient setting is very different than the inpatient setting. I'm pretty sure that it's going to stick in the outpatient setting.
Hopefully.
Yeah.
Fingers crossed.
I would say just real quick, yeah, inpatient right now does have pay parity. It's the same CPT. If you're actually in the physical facility, there's essentially no modifier. If you're outside the facility doing telemedicine services, there is additional modifiers there. But I think, you know, maybe this is a good ask for SOHL members and those associated that, you know, to make this sustainable, we really need to make sure that pay parity exists for professional services. So if you all feel empowered to advocate on everyone's behalf, that would be great.
Wonderful ask. Thank you. Well, I really appreciate, sorry, I ran over a few minutes, but really appreciate all of our speakers. Let's all thank with virtual claps in here for you. Thank you. And I'll hand it back over to Jack. And Jack, maybe you can even answer the question that was put on the chat about whether or not the slides here will be made available for everybody in the audience. Thank you.
Perfect segue. Thank you very much. Thank you everyone for joining this afternoon's webinar program. If you have any other program recommendations or other items you'd like to learn about, please email us at soulprograms@gmail.com. We'll be sending out the slideshow to all our registered invited guests, and that will include a link to the recording as well. So once again, thank you everybody. Have a great rest of the day.